Hi, I'm Douglas DiRuggiero. I'm a dermatology PA that practices in Rome, Georgia. I'm the co-editor of the Journal of Dermatology for NPs and PAs. And I have the honor of being here with not just a colleague, but a friend that I've had for 10 or 15 years now, right? This is Kirk Gautier, and he's a dermatology PA that practices in Texas and has been practicing for 21 years doing skin. And Kurt, I consider you an expert in so many areas, but we want to focus our time today on atopic dermatitis. We've had kind of a fun renaissance of therapies in this disease state, and we could go into a deep dive, you and I both, on the biologics, the oral JAK inhibitors, topicals that are out now. But I want to pick your brain with the combination of a JAK inhibitor that is a topical cream, our topical ruxolitinib or Opzelura. Let me put it to you this way. If you feel like you have a patient in front of you, and it's indicated down to age 12, so we're talking about somebody who's 12 and up, okay, and you think that they're a great candidate for this or you want to offer it as an option, what are the main points? If I was a student rotating with you or a resident in the room and you said, come in here, I want you to hear the way I'm going to present this particular option to this patient, what is the practical way what are the practical points, the 2 or 3 points you want to make sure that mom hears or that adult hears about what to expect, what to anticipate, things they may look up? How do you address the issues when you want to prescribe this particular topical JAK inhibitor?
If they are coming to the dermatology office for probably the first time from their PCP, I don't think that they've seen many things other than the triamcinolone, the betamethasone, or God forbid, the lotrasone that somebody keeps writing them, causing thinning of the skin and atrophy and stretch marks. So they know that, they've seen that, they've all Googled like steroid withdrawal and dependence. So a lot of times if they don't want a topical medication, they're specifically talking they don't want a topical steroid. And thank God we have a couple of other options to offer them.
So it is true, patients do read up about these things, and I think I'm seeing more and more people coming into the office who do have steroid phobia. I used to have to educate them on it. Now I'm seeing more moms that are saying, I've looked up the problems with steroids and I really don't want that. So if we're going to encourage them towards, let's say it's a patient, it's mild to moderate, and it's appropriate to try to keep them on a topical, what's the presentation like for you if you're going to talk to them about using Opzelura?
Okay, specifically Opzelura.
Yeah, let's dive in on that one.
Back to step one, topicals are an option. What are they bathing with? What are they washing? It's amazing how many people were like, well, I use my grandmother's soap. And we're like, well, do you know the pH of that soap? Do you know the micelle size of that soap? And of course, they don't. So let's get them on an appropriate cleanser. Talk about just bland moisturizers. I think they've all kind of done lots of different things. They've had some of the craziest stuff they've tried. And then if we do in our mild to moderate patients, these are usually people who just have a couple of areas that they cannot leave alone. They're really tearing up the antecubital fossa, the wrist, the back of the knees, the popliteal. Gosh, that's a great area for a treatment like Opzelura, especially in the patients who don't want steroids or the family who doesn't want any kind of steroids. And then you get buy-in pretty quickly because the efficacy starts to work, maybe overnight. I think they have 15-minute data. Is that right, Douglas?
I think so.
Yeah, that's insane. So you can give somebody maybe a sample and say, hey, you know what? Start a timer on your watch, okay? I just want you to watch her scratch, put the medication on, look at her again in 30 minutes and see if you see her attitudes, her actions have changed. And my last female patient I can think of. And the parents will call back and they're like, oh my gosh, you know what? She went hours without like clawing at herself. And when she did start to claw at herself, I think it was more out of habit than like actually itching. It can be very dramatic and amazing. And then if you get that buy-in, of the patient's family, the patient having some success with it, they're more likely to want to use the medication, more likely to be adherent to the therapies that we would like to give them.
All right, I like that idea. So you actually encourage your patients to put it on and to be very cognizant of their itch going down in the first hour, the first 2 hours, and certainly that first day. And so that's kind of giving them an expectation, because I like to leave patients with expectations, you know.
Yeah.
I think if you put this on, the company has data that shows you're going to get great itch relief in the first 24 to 48 hours, even sometimes down to first 15 minutes.
That's great.
And
That's
I want you to come back and tell me if that's the case for you. And I think patients will look out for that. Now, I mean, this is a topical JAK inhibitor. So do you go ahead and edge into the discussion thinking that they may look this up and see that there are some box warnings
I expect they will look it up.
And so how do you navigate that conversation or that presentation? What is that like for you to say, look, you know, this is a topical cream, and you may look something up, and how does that, again, if I'm a student sitting there, how would I hear you make that presentation?
There's never been a medication that has been approved for the FDA as an oral medication with no black box warning, that when it finally gets put in a topical form, because the size of the molecule is so small, they actually put a black box warning on it. And I tell my patients that this is it. This is the only one that I can find, or that I know of or ever heard of, where the FDA did this. And they did it at a time where we were having some releases of some other JAK inhibitors, and they were rubber stamping black box warnings on all of them. I don't know why they did that. They did. It's impossible to put enough medication on to get an oral dose of the original JAK inhibitor called Jakafi. So I lay it out.
So what you're saying is that, you know, when the first oral was approved, oral ruxolitinib, Jakafi, in 2011, and then it was approved, you know, for this myelofibrosis, and then it was approved for polycythemia vera, and then most recently, 2019, approved. So every time it goes to an approval, the FDA looks at the data again. In 2019, it was approved for graft versus host. And what we're saying is that this, and with all of those new indications, they have never put a box warning on the oral ruxolitinib. So what's so unusual is that when the topical ruxolitinib came out, it received box warnings that was underneath the umbrella of other JAKs and not tethered to its original oral compound.
Exactly.
I don't think a lot of people know that. I don't think a lot of prescribers realize that that's a good point to make.
If we have another medication we could think of, when topical tacrolimus came out,
Right.
it got a black box warning because oral tacrolimus was known to cause some lymphoproliferative problems. So they just rubber stamped topical tacrolimus. So I think we've seen something like that before, but this is different.
Yeah.
This is an oral medication without a black box and a topical with. And so I lay that out to the patients. I say, you know, this really doesn't make a lot of sense from what the FDA did. We have to use it on a small body surface area, less than 20%. Which that's going to be for my patients with mild to moderate, you know, eczema. That makes complete sense. But I really like the speed of action. I love the fact that you can put it anywhere, and I don't have to worry about stretch marks. I don't have to worry about atrophy. I don't have to worry about stria. I don't have to worry about rebound, like of the steroid-induced, you know, addiction. I don't have to worry about that kind of stuff. It works really quickly, and then once they're better, okay, stop it. it. And if your itch comes back, hit it again. This is probably going to be something that we're going to have to treat through your life unless you outgrow it as a little kid. But you know, in the clinical trial, I believe, didn't they have like 4.5 months of drug holiday?
I don't remember the exact numbers, but I know that it's indications for that non-continuous use, and they had long periods of time between times when they had to go back and reapply.
Yeah, so that'd be great. I just imagine kind of going the whole summer and maybe needing your medication if it's really successful for you.
You know, it really is. I mean, you've been practicing long enough, I have too, to not have any of these great alternatives. We had topical calcium inhibitors, which you mentioned, and you know, they had problems with tolerability, with stinging, and efficacy being, you know, mediocre. Even the, you know, topical crisaborole, again, mediocre. But now to have multiple non-steroidal options that we think really work well, and a topical JAK inhibitor, which we know the oral JAKs are very effective, and to have a topical JAK is just, it's really cool to be practicing at this time.
Yeah, hitting multiple pathways.
Yeah.
On
it's a targeted therapeutic in a tube.
Right. And
I never thought we'd have targeted therapeutics coming out of a tube. We always thought the target was going to be, you know, mostly through
shot
a
or-
shot,
yeah.
you know, through a shot. So, well, I appreciate you being here. Those are some great clinical pearls that you have shared with me. I'm always learning from you and from everybody that was here too. So thanks for being here, and thanks again for joining us. And we appreciate your time, and we hope that you've learned something from this.